Good evening, students. Today we will discuss antimicrobial stewardship. First of all, we need to know what is antimicrobial. Antimicrobials are drugs that inhibit or kill microorganisms. If we move back into the pre-antibiotic era, we all know that many people lost their precious lives in this era because at that time no life-saving antibiotic drugs were available to treat the fatal infectious diseases. So it used to take a huge toll, and this situation continued till the year 1940. In the year 1940, Sir Alexander Fleming discovered the first antibiotic, that is penicillin. Since then, many more antibiotics were discovered, but the problem we encountered was the antibiotics started showing resistance within a few years of their discovery. As for example, the antibiotic streptomycin, which was discovered in the year 1947, showed resistance in the year 1956. Similarly, chloramphenicol was discovered in 1949, but it showed resistance in 1970, and the list is huge. What are the types of antibiotic resistance? There are two types of antibiotic resistance. One is the intrinsic resistance and another one is the acquired resistance. So coming to the first type of resistance, that is intrinsic resistance. What is intrinsic resistance? In this type of resistance, the organism is inherently resistant to a particular antibiotic by virtue of its genetic makeup. The organisms are unresponsive to these antibiotics, although they appear sensitive in vitro. As for example, Enterococcus. So, an isolate of Enterococcus may appear sensitive in our laboratory test. Okay, but in reality, if we treat enterococcal infection with clindamycin or cotrimoxazole, it will not be effective at all because by virtue of its genetic makeup, Enterococcus is not at all effective with clindamycin. Okay, so remember that although clindamycin may appear sensitive in the culture and sensitivity test in the laboratory test, it is not at all useful in treating enterococcal infection. Similarly, Proteus infection can be treated with nitrofurantoin or colistin, and salmonella or typhoid fever infection cannot be treated with aminoglycoside because this antibiotic is not at all effective against the organism. Second type of resistance is the acquired resistance, which poses a therapeutic concern. In this type of resistance, the organism which was initially susceptible to a particular antibiotic becomes resistant in due course. How? By acquiring drug resistant genes from other bacteria. Now, what is the mechanism of acquired resistance? We all know that our body harbors two types of organism. One is the commensal and another one is the drug resistant bacteria. And in normal situation, a perfect balance is maintained between these two categories of organisms. Now, once antibiotic is administered in our body, what happens? This balance shifts. What happens is that due to exposure of antibiotics, the commensals are get killed and the drug-resistant organism continues to increase. So there is relative disproportion between the commensal and the drug-resistant organism. And this situation aggravates on continued exposure to the antibiotics. And at one point of time, there is overgrowth of drug-resistant organism, and this organism keeps on transmitting the drug-resistant gene and promotes emergence of more virulent organisms. Now, what are the factors contributing to antibiotic resistance? First and foremost is the over-the-counter sale of antibiotics without a valid prescription. Now, most people don't want to seek a medical consultation for a minor illness. They don't want to give the fees of a doctor. Rather, they feel safe while procuring a drug from a pharmacy. The pharmacist will easily give antibiotic to these patients for his profit. And what happens? The patients will take antibiotics in suboptimal dose or a suboptimal duration, and this will lead to selective antibiotic pressure and will lead to emergence of drug resistance. Antibiotic therapy in viral illness, same as I told earlier, that for mild symptoms, many patients will take antibiotics and many pharmacists will sell antibiotics for the sake of their profit. So, this leads to antibiotic resistance because there is no bacteria in the field and the antibiotic is doing nothing but increasing the antibiotic pressure on the common cells, and this increases the emergence of drug resistant organisms. Third one is treatment of colonizers. Many doctors have a tenacity to treat drug-resistant organisms even if there is minimal symptoms in the patients. They treat the culture report, not the patients. So whenever they get a culture report entering the organism is having a multiple resistance to antibiotics, they will straightway treat the patients with higher antibiotics, and this lead to increased selective pressure of antibiotics to the commensal organism present in the patient's body, and this leads to emergence of antibiotic resistance. Another cause is increased antibiotic use in poultry farm. What happens? The poultry farms use an antibiotic named as colistin, which is a reserved antibiotic. This antibiotic is used to boost the growth of chicken in a short course of time. So when the colistin is administered to this chicken, they already harbor the colistin resistant organism in their gut. So once these chickens are slaughtered, these drug colistin resistant organisms are getting transferred to their fleshes. And when we process these fleshes in our kitchen, suppose the same knife we use to cut the chicken pieces are used for cutting the vegetable and preparation of salad. So if these food materials are not properly cooked, the bacteria which contains drug resistant genes are not killed properly. And when we consume these improperly cooked or undercooked food, these organisms are easily transmitted to our body. Got it? But don't worry, bacteria can't sustain high temperature. So if the foods are properly cooked, the bacteria gets killed, and not only the bacteria, the genetic material which is responsible for transmission of drug resistant gene for one bacteria to another also gets degenerated in this high temperature. So the vector for transmission of this drug resistant organism are completely destroyed in the high temperature of cooking. So don't worry, enjoy your meals after proper cooking. Now, what is the current scenario? On the one hand, there is less investment and research work on antibiotics. Why? Because the bacteria are smart enough, they easily develop the mechanism to bypass these antibiotics. So, the pharma companies are least interested in investing more on antibiotics because within a few course of time, the antibiotics will become resistant and their investment will go in vain. So they are least interested in development of new antibiotics. So on the one hand, there is a less number of new antibiotics, and on the other hand, there is more development of antibiotic resistance. So if this situation continues, then what will happen? We will easily enter into a state of post-antibiotic era, and this will be indeed a deadly situation. So, is there any way to overcome this situation? Obviously, yes. If we can implement a program at the hospital level or clinic level which ensures right antibiotic to the right patient in right time, in right dose, in right route, and in right frequency, then the situation can be easily controlled. This program is nothing but your antibiotic stewardship. So, in a nutshell, what is antibiotic stewardship? It is a program intended for rational use of antibiotics. So, what is the goal? What are the goals of antibiotic stewardship? The goals are to prevent emergence of drug-resistant bacteria. So, once we prevent the emergence of drug-resistant bacteria, it will automatically improve patient safety and outcome. And once patient safety and outcome improves, there will be indirect reduction of healthcare costs. Now, what are the steps of antimicrobial stewardship? First step is the development of antibiotic policy, preparation of antibiotic policy, and preparation of hospital antibiogram. What is an antibiogram? Antibiogram is a summary of the sensitivity profile of the organisms prevalent in your organization. And what is antibiotic policy? Antibiotic policies are the uh, narration of the antibiotic we use. It is a policy. What antibiotic we will use as empirical therapy or targeted therapy as per syndromic approach. Second step is to provide empirical therapy to the patient. What is empirical therapy? Uh, when we are treating an infection, we will send samples for culture, but is culture report immediately available? Obviously, no. It takes around 2 to 3 days time to get the culture report. So what will we do? We will not treat the patients. Obviously, we should give some treatment to the patient. So what will be our strategy? To overcome the crisis, we should start some antibiotic. So first of all, what should we do? We should send the samples for culture before starting antibiotic therapy. Now, to overcome the crisis of the clinical situation, to treat the acute crisis of infective syndromes, we should blindly treat the patient with some antibiotic based on the clinical status of the patient. Now, what is the dictum? For an unstable patient who is not hemodynamically stable, or patient who is having a constellation of symptoms, many patient is highly symptomatic. In that case, what should we do? There is high chance of infection with a deadly organism. So we should provide more coverage against many organisms. So for an unstable patient, we should go ahead with a broad spectrum antibiotic. Whereas for a stable patient with minimal symptoms, we should use a narrow spectrum antibiotic, which is having comparatively lower coverage than the broad spectrum antibiotic, because it is unnecessary to provide coverage for so many organisms in a clinically symptomatic and hemodynamically symptomatic patient. Okay. Now, once the culture report is available with us, we will decide our targeted therapy based on the sensitivity profile of the organism isolated. So, in targeted therapy, what we do, we either escalate or de-escalate the antibiotic. So, what is escalation? Suppose initially in the empirical therapy we have used a narrow spectrum antibiotic, but in the culture report we saw that the antibiotic we have chosen in the empirical therapy is less sensitive or resistant. So what will we do next? If there is sensitivity with the higher spectrum or broader spectrum antibiotic, we will shift from narrow spectrum to broad spectrum antibiotic. As we are shifting from narrow to broad, from lower to higher, this is escalation. Okay, for a clinically symptomatic and hemodynamically unstable patient, we are shifting from a lower spectrum antibiotic to a higher spectrum or broader spectrum antibiotic. This is known as escalation. The vice versa is the de-escalation. So, in targeted therapy, we should either escalate or de-escalate the antibiotics. Then, when we analyze the culture report, we should ensure that it is not a colonizer. What is the clue that the isolated organism can be a colonizer? Patient is having minimal symptoms, patient is hemodynamically stable, and the isolated organism in the culture is highly drug resistant. It is resistant to most of the higher spectrum antibiotics as well. And the other biomarkers which are suggestive of infection, that is CRP, procalcitonin, all are normal. The routine blood counts are normal. So many things are uh, against infection. But the culture report is showing a highly drug-resistant organism. In that case, we can stamp the organism as a colonizer. And we should not treat a colonizer at any cost. Ensure that the isolate is not intrinsically resistant to the chosen antibiotic. I discussed intrinsic resistance, so we should check that the antibiotic we are choosing to treat the patient are not intrinsically resistant against the organism we have isolated in the culture. This is the most important point, that the chosen antibiotic achieves appropriate concentration at the desired site of action. The antibiotic should achieve a proper concentration at the desired site of action. And we should switch from parenteral to oral therapy whenever possible, because unnecessary parenteral therapy incites infection. So, whenever possible, until and unless this is absolutely necessary, we should discontinue parenteral therapy and we'll switch to oral therapy. Consider local inhibitors present at the site of action of the antibiotic. For example, daptomycin is inactivated by the pulmonary surfactant. So, as daptomycin is locally inactivated by the pulmonary surfactant, we can't use daptomycin to treat a pulmonary infection. Abscess cavity needs to be completely drained for better penetration of antibiotic. If the abscess cavity is full of purulent material, so how come the antibiotic will be able to penetrate the cavity? And if the antibiotic is unable to penetrate the cavity, how will you treat the infection, the antibiotics will not be available locally because of this purulent material. So you should completely drain the abscess cavity before installation of antibiotic. Now coming to step 4, that is MIC guided therapy. So what is the concept of MIC? MIC means minimum inhibitory concentration. What is this? Suppose we are taking a sterile tube of liquid culture media. Now we are adding bacterial suspension into the media. What will happen next? For bacterial growth and proliferation, we need nutrients. And the nutrient is already there in the culture media. So once we add bacterial suspension in the sterile culture media, there will be bacterial proliferation. And will there be any change in the physical appearance of the media once bacteria proliferates? Obviously, yes. The media will turn turbid. Now, in a turbid media where there is adequate proliferation of bacteria, if we add some antibiotic solution, then what will happen? There may be two outcomes. If the antibiotic, if the organism is sensitive to the antibiotic we are adding, then depending on the dose of antibiotic added and the duration of exposure to the antibiotic, there can be two outcomes. One is the partial clearing because antibiotic will inhibit the proliferation and growth of bacteria. If there is suboptimal inhibition, then the media will be partially cleared. And if there is optimal inhibition, there will be total clearing of the media. For example, we are calculating the MIC of imipenem in a growth of E. coli. We have taken 6 tubes here, and in all the tubes we are adding some imipenem. Let's assume that the bacterial concentration in all these 6 tubes are constant, that is 0.5 Macfarlane units. Now in each of these tubes we are adding imipenem in decreasing order of concentration. So in the first tube the concentration of imipenem added is 4 microgram per ml, in the second tube 2 microgram, in the third tube 1 microgram, and so on. What we do next is we incubate this antibiotic treated bacterial suspension for overnight. Now what can we expect on the next day reading? As there was overnight exposure of antibiotics to the bacteria, what can we expect? There will be, if the bacteria is sensitive to imipenem, this E. coli is sensitive to imipenem, there will be inhibition of growth of E. coli to this imipenem. So next day, this is the scenario. Please note that in tube number 1 to 4, there is total clearing of the media. And in tube number 5 and tube number 5, there is partial clearing. And in tube number 6, there is absence of clearing of the media. So what is the minimum concentration of antibiotic that leads to total clearing of the media? It is 0.5 microgram per ml, that is tube number 4. So the minimum concentration of imipenem which is capable of clearing the turbidity of the bacterial suspension is 0.5 microgram per ml. So in this case, the MIC of imipenem in this isolate of E. coli would be 0.5 microgram per ml. Okay, clear? Now, calculate the MIC of amikacin in this isolate of pseudomonas. You please note that we have taken 5 tubes. Let's assume that the bacterial concentration in all these 5 tubes are constant, that is 0.5 Macfarlane units. And the amikacin doses in tube number 1 are 16 microgram per ml, tube number 2 8, and so on. And on the next day after overnight incubation, we saw this picture. In tube number 1 to 4, there is total clearing of the media, and in tube number 5, there is partial clearing of the media. So the minimum concentration of antibiotic, amikacin, that is capable of clearing the turbid growth of pseudomonas is 2 microgram per ml. In 1 microgram per ml, there is partial clearing, but up to 2 microgram per ml, there is total clearing of the media. So the MIC of amikacin against this isolate of pseudomonas is 2 microgram per ml. Now, what is the utility of this MIC? Why we should do this sort of hard work, this calculation of MIC? It's a technically cumbersome procedure. We need costly machine for determining this MIC. So, what is there any therapeutic implication for determining this MIC? Obviously, yes. How? For that, we need to understand the concept of therapeutic quotient. Each and every antibiotic have a defined sensitivity breakpoint as defined by the Central Laboratory Standard Institute or CLSI. Now, therapeutic quotient is the sensitivity breakpoint defined by CLSI for a particular antibiotic divided by the MIC value of the test isolate. Antibiotics with higher therapeutic quotients have better therapeutic efficacy, provided no difference is there in the pharmacokinetics and pharmacodynamic properties of the drugs. Let's see an example. A patient is admitted in ICU with septicemia. Blood culture reveals methicillin-resistant Staph aureus, which is sensitive only to vancomycin and teicoplanin. The MIC value of vancomycin is 1 and teicoplanin is 2. The sensitivity breakpoint of vancomycin is 2 and teicoplanin is 8. Among these two drugs, which one will have better therapeutic outcome? So what will be the answer? What did I say? That the drug with higher therapeutic quotient will have better therapeutic outcome provided there is no difference in pharmacokinetic and pharmacodynamic properties of the drugs. Both vancomycin and teicoplanin are nephrotoxic drugs, and both this is the case of septicemia. So both these antibiotics achieve adequate concentration in the blood. So there is adequate concentration of both these antibiotics in the blood, and both these antibiotics have similar adverse reaction profile, that is nephrotoxicity. So among these two options, which one do you think that will be better for therapy in this case? So the one with higher therapeutic quotient will be obviously better for therapeutic for therapy in this case. So which one has which of the antibiotic is having higher therapeutic quotient here? It is for vancomycin. What is the therapeutic quotient? The sensitivity breakpoint of vancomycin is 2 and the MIC value is 1. So the therapeutic quotient for vancomycin is 2, whereas for teicoplanin, the sensitivity breakpoint is 8 and MIC value is 2. So 8 by 2 is 4. That is the therapeutic quotient of teicoplanin is 4. So the higher therapeutic quotient is for teicoplanin. So which one will have better therapeutic outcome? Obviously teicoplanin. No doubt regarding that. Now we will do some question and answer here. Coming to the first question, a patient underwent craniotomy 5 days back and has been ventilated since then. After 4 days of ventilation, patient developed fever, increased tracheal secretion, worsening respiratory status. Chest X-ray PA revealed consolidation and hematocele in the upper lobe of left lung. 3 samples of blood culture are sterile. The ETS revealed heavy growth of MRSA. The isolate is sensitive to vancomycin, teicoplanin, daptomycin, and linezolid with the MIC and breakpoint as mentioned in the table. So which of the following antibiotic is the least effective one in treating this patient? So what is this vignette indicating us? What is the case? A ventilated patient presented with fever, increased tracheal secretion and worsening respiratory status. Chest X-ray revealed consolidation and near consolidation. So the case vignette is indicating that it is a case of ventilator-associated pneumonia. So what will be our target organ for treating a patient of ventilator-associated pneumonia? What is the site of infection? It is the lungs. For treatment in a lung infection, is this daptomycin very effective? What I told in my earlier slide that we should consider whether any local inhibitors are present in the target site of action of the antibiotic. And I already told that this daptomycin is readily inactivated by pulmonary surfactant. So there is no question of therapy with daptomycin in a case of pulmonary infection because this antibiotic is not readily available in the site of action, in the site of infection, because it is readily destroyed by the pulmonary surfactant. If it is readily destroyed, then it will not achieve an adequate concentration at the site of action in the lungs. So it will not be effective at all in treating lung infection. So the least effective antibiotic will be daptomycin. Question number 2. A patient in ICU is snake bite and acute renal failure requiring hemodialysis. Central line was inserted immediately. After 4 days, patient developed fever. Provisional blood culture report issued from microbiology laboratory reads the following: heavy growth of gram-positive cocci. Patient is a known carrier of MRSA. Which of the following antibiotic will be the most effective empirical therapy? Now, as it is a case of the patient is a carrier of MRSA and provisional blood culture report is indicating heavy growth of gram-positive cocci. So there is high chance of bloodstream infection with MRSA. We should keep this in mind. And for treatment of MRSA, what are the recommended antibiotics? Recommended antibiotics for treatment of MRSA is vancomycin, linezolid, and teicoplanin. And gentamicin in combination with vancomycin or teicoplanin. So the primary drug that is effective in treatment of MRSA is vancomycin, linezolid, teicoplanin. But among these three, only two are available in our option, that is vancomycin and linezolid. Cotrimoxazole is not at all effective in treatment of MRSA, so it can be easily ruled out. Gentamicin is not used as a primary drug, so can be easily ruled out. So we are left with two options, vancomycin and linezolid. Now, what the question is saying that the patient is in renal failure, acute renal failure. So, among these two antibiotics, we should choose a drug which is having less renal toxicity. So, among these vancomycin and linezolid, which one is having less renal toxicity? It is linezolid. So, the best empirical therapy in this case will be linezolid. Question number 3. A 35 years old female develops fever, lower abdominal pain, and burning sensation during urination 3 days after vaginal delivery. Urine culture reveals significant colony count of E. coli. Patient is hemodynamically stable. Sensitivity report reveals significant growth of E. coli with sensitivity to all these four antibiotics with the MIC and breakpoint as given in the table. So, which of the following antibiotic would be most appropriate in this case? So, the patient is having urinary tract infection, so we should choose an antibiotic which is readily, which achieves the desirable concentration in the urinary tract. So, first see whether all these four achieve adequate concentration in the urine or not. Obviously, yes, all these four antibiotics achieve adequate concentration in the urine. Now, among these four, which one will be the best? In terms of toxicity, also imipenem is slightly nephrotoxic, so we can easily rule out imipenem. But the other drugs are comparatively less toxic. Now, which one to choose among these? Your adverse effect profile ruled out imipenem. Now, in among nitrofurantoin, cotrimoxazole, and ciprofloxacin, there is no significant adverse effect profile in urinary tract. Now, what should we see? Whether any local inhibitors are present in the urinary tract which can prevent the action of antibiotics. Significantly no, because no inhibitors are present in urinary tract against nitrofurantoin, cotrimoxazole, or ciprofloxacin. And patient is hemodynamically stable also, so we can easily go ahead with a drug with um, lesser spectrum or narrower spectrum. Now, what should we consider? The therapeutic quotient. Among these three antibiotics, which one has the highest therapeutic quotient? For nitrofurantoin, it is 16 by 1, that is 16. For cotrimoxazole, it is 12 by 2, that is 6. And for ciprofloxacin, it is 4 by 1, that is 4. So, the highest one with and the highest the antibiotic with the highest therapeutic quotient is nitrofurantoin. So the answer will be nitrofurantoin. Question 4. A patient attended a peripheral health center with symptoms of urinary tract infection. The medical officer advised for urine RE and culture. Urine RE revealed 15 to 20 pastel per field, and urine culture report revealed significant E. coli and significant colony count of Proteus mirabilis. The sensitivity report is as follows. The isolated organism is Proteus mirabilis. The antibiotics which are sensitive are nitrofurantoin, cotrimoxazole, ciprofloxacin, and coamoxiclav with the given MIC and breakpoint. So, which of the following antibiotic would be most appropriate in this case? So, the site of action will be urinary tract. The isolate is Proteus mirabilis. So among in the urinary tract, are all these antibiotics effective? Obviously, yes, nitrofurantoin is effective, cotrimoxazole is effective, ciprofloxacin is effective. Amoxicillin is a little bit less effective in urinary tract infection, so can be easily ruled out in this case. Among nitrofurantoin, cotrimoxazole and ciprofloxacin, we will have to choose. Now, what is the isolate Proteus mirabilis? Uh, Toxicity profile of both all these three nitrofurantoin, cotrimoxazole, ciprofloxacin are insignificant in urinary tract. So the next point to consider is local inhibitors. Local inhibitors are not available in urinary tract against these antibiotics. Next factor, whether any intrinsic factor is whether any antibiotic we are choosing is intrinsically resistant to the organism we isolated. Now for Proteus mirabilis, we can see that nitrofurantoin is intrinsically resistant. So for Proteus mirabilis infection, we can't use nitrofurantoin. So we have eliminated nitrofurantoin and coamoxicillin. Then the available options are cotrimoxazole and ciprofloxacin. So although nitrofurantoin is having highest therapeutic quotient in this case, that is 8, we can't give nitrofurantoin. So next drug with second highest therapeutic quotient is cotrimoxazole. For the cotrimoxazole, the therapeutic quotient will be 12 by 2, that is 6, and for Cipro, it is 4 by 1, that is 4. The higher among cotrimoxazole and Cipro, the drug with higher therapeutic quotient in this case will be cotrimoxazole. So the drug of choice will be cotrimoxazole in this case. A patient with known history of benign prostatic hypertrophy presents to the surgery OPD with complaints of burning pain while passing urine. Urine culture revealed significant coronary counts of Klebsiella pneumoniae. The culture report is as follows. The isolated organism is Klebsiella pneumoniae with sensitivity to nitrofurantoin, cefixime, ciprofloxacin, and cotrimoxazole, with MIC and breakpoint as given in the table. So which of the following antibiotic would be best for targeted therapy here? So among these four, which one is readily available in urinary tract? All these four are readily available. Next point to consider, whether any local inhibitors are present or not. No local inhibitors are present in urinary tract against these antibiotics. Next point to consider, is there any intrinsic resistance of this antibiotic against the organism isolated? For Klebsiella pneumoniae, the intrinsic resistance is seen in ampicillin and triclosan, and it is not intrinsically resistant to any of these nitrofurantoin, cefixime, cipro, and cotrimoxazole. So now the point to consider is the therapeutic quotient. So among these four options, which of the following drug has the highest therapeutic quotient here? Obviously, nitrofurantoin. It is having a therapeutic quotient of 18 by 0.5, that is 36. For cefixime, it is 10 by 2, 5. For Cipro, it is 4 by 2, 2. And for cotrimoxazole, it is 2 by 2, 1. So the drug with highest therapeutic quotient is nitrofurantoin. So the answer will be nitrofurantoin. So the take-home message will be, always follow the hospital antibiogram and antibiotic policies of your hospital. Try to send samples before initiation of antibiotic therapy. Empirical therapy to be chosen based on clinical status of the patient. Targeted therapy to be chosen based on pharmacokinetics, pharmacodynamics, and therapeutic quotient of the drug. I hope you enjoyed my presentation. If you really liked my video, please like, share, and subscribe my channel. And thanks a lot for patient hearing.